continue to look at the impact this development will have on the community and NGO-based employment and on rural health altogether. Director at the Rural Health Advocacy Project, Russell Rensburg, and Public Health Medicine Specialist at ANOVA Health, Dr. Kate Rees, join me now to weigh in. Good morning to the both of you.
Good morning, Mr. Chaba.
Now, firstly...
Good morning. Thanks for having us.
Thank you very much for your time. Firstly, Russell, let me start with you. What are your thoughts on the sudden termination of US aid-funded HIV projects in South Africa?
I think firstly we have to start with and thank the American people for the investments that they have made in the HIV response in South Africa. I think without those investments over the last 20 years, we wouldn't be in a position now where we're very close to epidemic control. That being said, this sudden shift and stop of funding will have a significant impact on the country's strategies to find the missing million patients, as well as, starting stronger preventative efforts, especially amongst young women and girls, where we relied on the support of the American people in the year ahead. But the change has happened. It's 60 days ahead of schedule. We didn't even complete the full 90 days. So I think the transition process will be hard, but it is an opportunity for everybody to come together and start seeing what are the things that we need to do now. And in rural areas, the impact will be significant because PEPFAR operates in around 27 districts. I would say 80% of those are in rural or areas or the like. So the impact on rural health systems will be significant unless there's a significant investment. And I think with the budget coming up, there is an opportunity for us to sort of place these things as placeholders in the budget. And I think we called for a 30 billion rand health bailout, that would address some of the implementation challenges at the province, as well as allocate insufficient funding to integrate the very important services delivered by PEPFAR partners.
And Doctor, how do you think the US aid funding cutoff will impact the availability and the quality of medical care in rural areas, particularly for vulnerable populations such as the elderly, women and children?
So there are a number of ways in which the USAID funding has really been bolstering or complementing what the department has been running. Some of those really important ways are around things like advanced HIV disease, people who are really unwell and need special attention, perhaps from doctors, people who are at high risk, pregnant women and babies, following up on their results, following up on missed appointments, community testing. So there are quite a number of kind of complementary areas where USAID funding has really been helpful. Also, I think a big one is around counseling and ensuring that people understand HIV, their treatment literacy. So all of those are going to be immediately affected. Another really important component is prevention. We've relied quite heavily on PEPFAR for prevention, and this is something that we really need to step into immediately.
All right. Russell, how many jobs would you say are at risk in light of these circumstances?
Well, it's a fair amount of job. I think it depends, because the support is at different levels. There's support to research institutions, and then there's support to direct delivery through implementing partners such as ANOVA and others. So our estimation is just over north of 15,000 people, direct jobs that are affected, and that's a broad range of health professionals. And I think some of the most important ones that maybe don't get enough mention are the data capturers, the lay counselors, the community health workers, who are often located within clinics that, like Dr. Kate says, facilitates like easier access to testing. And I think it's important as we look for the 600,000 or odd men who are currently not engaged in treatment. It's the youth, the outreach services, often at a district level. So direct engagement and strengthening of the health system. So I think as much as the transition could be complicated, I think there is an opportunity here for us to act immediately to ensure that there's continuity of those services. And a special mention as well to the data captures, because without good data and good data analysis, we can't actually manage this transition well. So I think there are lots of opportunities, there's significant impacts, but I am aware that conversations are ongoing, and hopefully in the next week or so, we'll see more direct communication from the government around how it plans to transition these important programs over the next while.
And speaking of which, Doctor, what role can medicine specialists play in advocating for policy changes and increased funding to support rural healthcare initiatives?
I mean, it's incredibly important for public health specialists and other healthcare workers to understand their role as advocates and activists for policy and for political change that benefits their patients, their communities. We know how important it is to speak out and to speak out for the people who cannot. And I really appreciate Russell talking to the data capturers, because in terms of the job losses that my implementing organization and many similar ones have suffered, it is the data capturers and community health workers that I really worry about. And if we don't speak out for them, they aren't often given a voice. And so it's really important for public health specialists and others who are in a position to speak out, to use their voices. We understand that health is political, there's economic factors to health, and we need to be clear about what is needed from the government, from civil society, from other stakeholders in order to come together and to benefit people's health in the long run and in the immediate crisis like we are having now.
Russell, is the National Health Department providing the required leadership during this crisis?
Could they have communicated earlier and stronger? Yes, but national government, as Kate says, operates within the broader political economy of South Africa. And I think funding and lots of negotiations and stuff needed to take place. So I think there's been discussion with the Treasury, there's been discussions with development partners. And, in fairness, they thought they had another 60 days to sort of manage this transition. So the hard stop in March was a bit of an outlier. But I think, yes, they could have done better. But within the constraints, I hope that in the coming weeks, we'll be able to have a conversation between all the different stakeholders on understanding how we manage the transition, as well as what we can and can't do. I think the important stakeholders here are political parties, like the Democratic Alliance and the African National Congress, who are very central to discussions, as well as the inclusion of civil society groups, like the South African National AIDS Council, which is a multi-sectoral body bringing everybody together. So this is a big crisis, but I do think it's a massive opportunity for us to sort of refocus. The French have the saying that sometimes you have to take 2 steps back to accelerate faster. And I think this is the opportunity we have now. We've had some amazing successes with HIV and TB over the last 20 years. A lot of that stuff is at risk. We have close to 78% of people who know their status on treatment. Almost 95% of those people are virally suppressed. And if we can just do that final push to get that extra 1 million on, we can reduce the impact of HIV and AIDS as a public health threat. But it also presents an important opportunity for us to go back to the drawing board on how we strengthen district health services. And I think here, when we integrate these things together, we have an opportunity now for the public health specialists, for the health policymakers and the politicians to start putting the country before ideology and start focusing and strengthening district health services so that we can serve 80% of the population where they are, when they need it, at very little cost or free to them. So this is the opportunity. And I think over the next weeks, that's what we have to see is the future that we want, rather than the crisis that we're emerging from. And I think South Africa is more than capable of funding its own response.
All right. Well, I'd just like, in closing and very briefly, Doctor, as we speak about solutions to round it off, or what are some of the most promising medical innovations or interventions that could improve health outcomes in rural South Africa? And how can these be scaled up or replicated?
I think we're really not looking for medical solutions at this point in time. There are really critical medical and clinical interventions coming through with HIV. With TB, we would like to see more development, especially around vaccines. But what we really need in our rural health spaces and in other spaces around the district health system is health system strengthening. And that means, we have whatever wonderful interventions coming out. For example, we've got our 6-month injectable PrEP, long-acting PrEP, which is really, really exciting. But how do we actually deliver that to people in South Africa? So besides the budgetary and affordability constraints, do we have the infrastructure we need? Do we have the staffing that we need? Do we have the correct financing models? All of those things are, and especially at the district health level, at primary care level, do we have the investments in primary care level? Is the governance and management of the district, of the clinics, of the hospitals where we need it to be at? Those are the things we need to be focusing on. And that's really what is going to strengthen the district health system and allow improved rural health for our communities.
Thank you so much. Thank you, Doctor. Thank you, Russell. Thank you both for your time.